Hi, and thank you for joining us for this CCO Live webinar titled Navigating the Complex Treatment Landscape in Relapsed Refractory Myeloma. My name is Kristen Rosenthal, and I'm Associate Director of Scientific Services with Clinical Care Options. This program is provided by Medical Learning Institute in partnership with Clinical Care Options and supported by educational grants from Janssen Biotech, Karyopharm Therapeutics, and Regeneron Pharmaceuticals. I'm honored to introduce our faculty for today's program. Dr. Paul Richardson, R.J. Corman Professor of Medicine at Harvard Medical School and Clinical Program Leader and Director of Clinical Research at the Jerome Multiple Myeloma Center at Dana-Farber. We also have Dr. Natalie Callander, Professor of Medicine in the School of Medicine and Public Health and Director of the Myeloma Clinical Program at the University of Wisconsin. And last but not least, Dr. Noopur Raje, Director of the Center for Multiple Myeloma at Mass General Hospital Cancer Center and Professor of Medicine at Harvard Medical School. Please note that we will be performing an assessment of this education with polling questions in this activity being asked twice, once before the content and then again later in the activity. Your individual responses will not be identified, and discussion of the correct answers will occur during the webinar. When a new polling or survey question pops up on your screen, please click Vote next to your answer. Please note that due to internet lag times, polls may pop up slightly earlier than when you hear a faculty read the polling question. Once the presenter moves on, the poll will close and you will no longer be able to answer it. You may also submit questions to our faculty by typing them in the questions window on the left-hand side of your screen. You may type in questions at any time during the program, and our faculty will try to answer as many as possible during the audience question and answer session at the end of this program. If you experience any technical difficulty, you may click on the Request Support icon at the very bottom left of your screen for live help. Also, at the end of this program, please click Claim Credit in the resources window at the bottom left-hand side of your screen to evaluate this program and receive credit. Finally, downloadable slides from this webinar will be available on the CCO website soon. Now let's start with a few quick polling questions so our presenters can get to know the audience. The first question is, which of the following best describes your role on the oncology care team? Great, it looks like we have a wide variety of people in the audience, some physicians, some pharmacists, other allied health professionals. So the next poll, which of the following best describes your specialty? Okay, it looks like most of us are hematology, medical oncology, which makes sense. So the next question, which clinical setting best describes your practice? Okay, so two more questions for you. Which of the following best describes your practice setting?
Hello. Hi, Sarah. How are you?
Okay, we have almost half and half academic and community. And last question for you, for those providing patient care, how many patients with multiple myeloma do you see in a typical month? All right, looks like we're a little bit split on this as well. So now it is my pleasure to turn things over to Dr. Callander to start us off.
Okay, good morning. Thanks for joining us here today. I'm going to start the discussion off by talking about early relapse of multiple myeloma. And here's my outline here. In the interest of time, I'm not going to belabor this. I'll let you read it. But we're going to start off with a case presentation here. And the first case is a patient of mine, a 79-year-old man. As you can see, looking at the vignette here, he was actually diagnosed with high-risk multiple myeloma. So he presented with acute kidney injury, creatinine of 4.5, high M protein of 5.4, and he had high-risk cytogenetics with a translocation of 14/16 and an AMP of 1Q. Now, he is 79, so he has some underlying coronary artery disease, but he's quite active, and he's married, he's a scrap dealer, and he wants to go back to work. Now, initially, at the time, because of his renal failure, we chose to treat this patient with Cyborg-D, cyclophosphamide, bortezomib dex, and then he was transitioned once his renal function improved to RVD light. We then put him on, because of his high-risk status, RVD maintenance, but he came into clinic about a year later complaining of sort of lower left back pain and leg pain. And we noticed that although his hemoglobin and his creatinine were actually normal, that his M protein was up to about 0.3. And he tells you that he wants to maintain his lifestyle. Now, the next case is, the next question is given this scenario, what would you choose to treat this patient? Would you retreat him with Cyborg-D, crank it back up to RVD light, Len-Dara-Dex, Pom-Dara-Dex, carfilzomib, isatuximab dex, or just not sure? So we'll let you vote. Okay, so interesting. So I chose to treat this patient with pomalidomide, daratumumab, and dexamethasone, and I'm going to tell you a little bit about that at the end, why I think that was the right decision. So let's talk about a second patient case here. This is a little bit different. This is a person with probably low-risk relapsed myeloma. 67-year-old woman came in with standard risk disease. She was enrolled on a clinical trial and received carfilzomib, lenalidomide, and dexamethasone. She was actually in remission and on lenalidomide maintenance for a number of years and was in a stringent CR. And now she comes back in for follow-up. She feels great. Her labs are okay, but now she has a reemergent M protein of 0.9 grams per deciliter. She has a few medical problems, and she tells you that she doesn't want to come in very often, and she wants a short duration of therapy. So what might be your options here? And let's have you vote again. And that's carfilzomib Pom-Dex, Dara Pom-Dex, bortezomib dex and Dara, elotuzumab Pom-Dex, or an auto stem cell transplant were the choices. Okay, again, a nice kind of split of answers. Now, in this particular individual, I chose to have her go through a salvage autologous stem cell transplant, and I'll talk about that at the end. So I think everybody here who treats a lot of myeloma, and I see that we've got people who treat many, many patients with myeloma, I think everybody's quite familiar now with the fact that in both transplant eligible and ineligible patients, we can get pretty good control of the disease in most patients for prolonged periods of time now, years in fact. But inevitably, most people are going to relapse. And we certainly understand that at each subsequent relapse, probably the number of patients that are going to respond is going to decline as long as the length of time that we're going to control the disease. Now, I have the easier part this morning because I'm going to talk about first relapse, where we're starting to have many, many, many choices. But the first thing, if a patient's relapsing, we got to sort of define what that is. And so on the left here on this slide, the International Myeloma Working Group definitions of relapse are there. Right now, we define it as 0.5 grams per deciliter of an M protein or 10 milligrams per deciliter, 100 milligrams per liter of light chain elevation, or 200 milligrams in a 24-hour urine collection. It gets a little bit tougher to say whether you've got a worsening bone lesion, but a new lesion would certainly count. And again, circulating plasma cells, and if a bone marrow biopsy showed more than a 10% increase in plasma cells. Now, we define a patient as relapsed and refractory if this is all occurring within 60 days of therapy or on therapy. So once you decide a person is relapsing, I think you can really split these up into two groups. And this is what our cases are illustrating. So there are patients who clearly have a biochemical relapse. In other words, they feel fine, but all of a sudden they're starting to show some progression of their labs. And there are some of those patients that I think we would agree that maybe if it's a particularly slow increase, that we might be able to sort of watch them for a period of time. Now, on the right, though, are those patients, particularly those like case number 1 with high-risk disease, where I think there's widespread agreement, and particularly if they have symptoms, that you're not going to sit on that. So if a person comes in with anemia or high calcium or worsening renal insufficiency, or certainly a new bone lesion, that is somebody that's going to need therapy pretty urgently. So the next approach is we have to reevaluate these patients. Now, of course, we're going to use the standard labs, but some of the things that can be quite helpful here are things like checking an LDH, which can be elevated, or a beta-2 microglobulin, which can be high, as say if a person has more of a non-secretory relapse, that can be used to follow. There has to be some sort of advanced imaging because a bone survey just doesn't cut it probably in any situation at this time, but certainly at relapse, you want to use something that can help you look for bone disease if it wasn't there before, or something like a whole dose low body CT, and certainly for extramedullary deposits with PET imaging. Bone marrow biopsies can be great if a person has falling counts. You always have to think about biopsying a new lesion, particularly if it's in a weird place. But for example, if somebody comes in with a liver lesion, and more we are seeing people who live long enough to have 2 cancers, not just myeloma, you certainly probably want to biopsy that and not just assume that that's myeloma. And also it's important to know that some people can have a different presentation at their relapse. So by an example for advanced imaging, this is our first case. And if you look on the left, this was the plain films that were done on the day he came in complaining of some back and leg pain. So he had some compression fractures that you can see, but they really didn't look very different from diagnosis. But if you look at the right, this is an MRI that was done about 3 days later, and the entire S1 vertebral body is now replaced with tumor, and that's what was causing the pain. Plus, you can see there are a number of other lesions there that you're completely missing on those plain films. Now, by different presentation, I think it's important to understand that some patients at relapse, particularly those with advanced relapse, either stop making an M protein or they stop making much protein at all. And that makes it quite difficult to diagnose the relapse as well as follow it. So this is a case, if you look on the left here, a graph showing in blue in that line, this person at diagnosis had a very high M protein, but at the time that they relapse 18 months later, that M protein is essentially undetectable, although the light chains are rising. And this is a phenomenon, if you see enough relapse myeloma, you're going to get very comfortable seeing and thinking about. So we've reevaluated, but now we have to review. So what was the patient on at the time of relapse? Nothing, or maybe they're even on triple therapy, which can make things more complicated. What kind of classes of agents have they received? Do they still have treatment emergent side effects? So do they have neuropathy, for example, or did they have trouble maybe with carfilzomib? Do they have coverage for oral chemotherapy? Do you have a clinical trial? Are they frail? Are they certainly now much older than they were at the beginning, and now they can't tolerate a more intensive therapy? Do they have that high risk versus standard risk disease? How close do they live to your clinic? And do they have a caregiver if you're going to give them a more complicated regimen that requires more support? Do they have previous autologous stem cells collected? And do they have other medical comorbidities? Now, first, we're going to take a look at some of the FDA-approved triplets, and in many cases, if a patient is fit enough, that's what we're going to recommend outside of a clinical trial, and particularly if the patient has not had a monoclonal antibody at the time of their first relapse, that's a very strong consideration. And these are all very reasonable choices. The circumstances where they might be applicable can differ, but daralendex, POM elotuzumab dex, ISA-POM dex, dara carfilzomib dex, and ISA carfilzomib dex, and dara bortezomib dex. And we're going to look at a few of those in a minute. And then, of course, if patients are on, say, a monoclonal antibody at the time of relapse, and maybe they're also on another agent such as lenalidomide, switching to something like carfilzomib POM dex or other carfilzomib combinations, thinking about pomalidomide bortezomib dex, Selinexor or bortezomib dex, and then there's some oral regimens to consider, such as pomalidomide, cyclophosphamide and steroids, or ISA-POM dex, which was recently updated. So let's just look at some of the trials I mentioned. Probably the jewel of all of these is the Pollux trial. Now, again, this was daralendex in patients who were not refractory to lenalidomide. So that's probably not that reflective of the US population, but suffice it to say, if you had a patient who has not received an anti-CD38 antibody and was not on len, this is a very good choice. Excellent PFS, 44.5 months versus 17.5 for Lendex, and very good overall response rate approaching 93%. So certainly a very reasonable choice and typically well tolerated even by older patients. Now, for those who might have received lenalidomide, you can think about something like the Callander trial, daratumumab with Velcade and dexamethasone versus bortezomib and dex. So this is a trial where the patients were a little bit more heavily pretreated. About half of them were refractory to IMiDs and some of them had transplants. But if you focus on people receiving the first line of therapy, which is the top line in the second graph there, you can see that very high PFSs of 27 versus 7.9 for just bortezomib and dexamethasone. So again, a reasonable for choice at, say, perhaps somebody who came in refractory to lenalidomide. Then there's Callander. Now, this is intravenous daratumumab combined with carfilzomib. Very high response rates actually in both arms. But if you start to look at progression-free survival, very much favors the triplet again, 28.6 months versus 15.2. Now, all of the last two trials that I mentioned, both Callander and this trial, the dosing is probably not what you're going to do practically speaking. So this is twice a week carfilzomib. The previous study was twice a week bortezomib. I think most people feel very comfortable when they're using these triplets in real situations to back it off to weekly. And I think that's what most of us do. And then, of course, if we start to think about little heavier, more heavily pretreated patients, there's Apollo. Now, this is subcutaneous daratumumab combined with Pom-Dex. Very good response rates in a median of 3 lines of therapy. If you look at the PFS, now you're starting to see, because these are more heavily pretreated patients, a little bit of decline. Median PFS of 12.4 months versus 7 months, but again, very well tolerated regimen in most patients. And then we can move on to Icaria, looking at Isa-Pom-Dex, isatuximab Pom-Dex versus Pom-Dex. This is a trial that Paul led. Very good response rates. If you look at the lower left box here, 63% for Isa-Pom-Dex versus Pom-Dex. Again, this is a much more heavily pretreated group of patients. And they even were able to show an overall survival advantage of about 25 months for those receiving Isa-Pom-Dex versus only 17 for Pom-Dex. So this is, again, a very reasonable choice for patients who might be refractory to lenalidomide. Now, how about isatuximab with carfilzomib? This is very similar in some ways to the Callander trial. This was twice a week carfilzomib again, but excellent PFS, 35.7 months versus 25. Versus 19. So this is very well tolerated. And again, dosing for this, most people would back down in real world to once a week carfilzomib to make sure that patients have minimal side effects. And then, of course, if we think about different antibodies than anti-CD38, there's elotuzumab with Pom-Dex. Again, this is more heavily pretreated patients. This was a phase 2 trial, but it did show an advantage for elotuzumab Pom-Dex versus Pom-Dex. This is a kind of regimen that personally I like in patients who do not have a very aggressive relapse, because sometimes it seems like the elotuzumab in particular is very helpful with this kind of patient. And then if we look at the Optimism study, now this would be a very interesting choice for patients who maybe had both a anti-CD38 antibody and lenalidomide. This is pomalidomide combined with bortezomib dex. Again, another study that Paul ran. If you look at the entire population, that the PFS was 11.2 months versus 7. But if you focus again on patients who are getting this in their first line of therapy, first line of relapse therapy, they do quite well with 20.7 months versus 11 months. So a very reasonable choice. And then we come to things like selinexor, bortezomib dex. Again, this might be a very reasonable choice in somebody who had had previous antibody therapy plus an IMiD. Again, overall PFS favors the selinexor. And I think one of the things we learned from this trial is that lower doses of selinexor are better tolerated and something to consider. Now, I mentioned that the Alliance trial was recently updated, at both ASCO and then the International Myeloma Society that just met. So this was a specific trial designed for patients who were progressing on lenalidomide, and that was really one of the criteria to get onto the study. And what they wanted to do is actually have a population that really reflected what happens in the US. So these patients could be on lenalidomide at the time they go on, almost mandatory that they needed to be, and then they were randomized to pomalidomide, ixazomib dex versus pom dex by itself. You can see a big PFS advantage for the ixazomib pom dex, 20.4 months versus 7.5. So for a person who might want an all oral regimen, this is an excellent choice to consider. Now, there's also another concept that I actually think is very interesting. And again, this would be for patients who might be len refractory. This was a study conducted in England called MUC5, where they decided to test two things. One was limited therapy, which of course patients are always interested in. So they gave a 24-week course of either bortezomib, cyclophosphamide dex, or essentially Cybor-D. And then they did a second randomization to either carfilzomib maintenance or observation. And they were able to show a couple of things. If you looked at the whole population, they really didn't see a big advantage for carfilzomib. But if the patients had high-risk disease, it really seemed like this might be a better choice. Looking at the PFS, 68%, or response rate 68% in those getting CD versus only 32%. And that choice of carfilzomib maintenance really did seem to benefit patients. So the PFS starting at the time of maintenance, 11.9 months versus 5.6. So a very interesting design. And then finally, for more advanced patients with more lines of therapy, we see things like CAR-POM-DEX. This is a single-arm phase 2 study. But again, for patients who are very heavily pretreated, that this is a reasonable choice, 10.3 months of PFS. So putting all of this together is, you can see that we try to split this up. I won't go through this whole thing in the interest of time, but you really want to decide, is the patient refractory to len? Probably then that is not going to be a big choice. No CD38 or other antibody drugs, definitely consider that in first relapse. We do think most of the time triplets are helpful if the patients can tolerate it. So if we go back to our cases, so I won't belabor this and read this all again, but as I mentioned, I chose to give this gentleman pomalidomide, daratumumab, and dexamethasone for several reasons. So one was, he was on essentially lenalidomide, bortezomib, dex at the time of his progression, and I really wanted to use different agents. The patient did have a significant history of coronary artery disease, and so I was kind of concerned about using carfilzomib, also given his age. And fortunately, this patient did respond quite well to pomalidomide, daratumumab, dex. And in terms of the second case, as I mentioned, I selected an auto transplant for this person. I thought that they would really benefit from the autologous stem cell transplant, given the sort of standard risk disease. And fortunately, this patient went right into a remission after auto transplant. She had no therapy because there was a low volume at relapse, right to the auto transplant, POM maintenance, and has been in a CR now for 2 years. So just to wrap this up, and just some of the points I made, probably consider a triple regimen for patients at relapse. Certainly for high-risk disease, we would recommend doing that. You try to pick different classes if you can, and certainly not use a class that you've used in the last 6 months. Obviously, if you're using things like bortezomib or carfilzomib or an alkylator-based regimen, you probably have to think about not indefinite therapy. A lot of patients aren't going to tolerate that. I do think sometimes we forget about auto transplants as a good salvage. There's data to support that, so something to keep in mind. Finally, unfortunately, when you're treating that first relapse, you still have to start thinking about subsequent relapses and what you're going to do next. That's what Paul and Noopur are going to talk to us about. And certainly we want to think about referring patients for CAR-T. So I'm going to turn this over to Paul, and thank you very much.
Great. Thank you so much, Natalie. That was absolutely superb. So it's my privilege to follow Natalie, and you'll hear even better stuff from Noopur in a moment. But I'm going to talk to you a little bit about the more challenging space of relapsed refractory myeloma, subsequent therapy, and beyond. But the way of starting our conversation, going to talk to you a little bit about a patient case to build on the two cases that Natalie so nicely showed you. The first patient is a 78-year-old lady diagnosed with lesion 17p disease and RISS stage 2 with IgG kappa isotype back in 2017. She got RVD-like maintenance did very well. Sorry, I apologize. RVD Light was one of our favorite regimens, and she got about 2 years out of that with maintenance contributing. And basically, she was on len maintenance alone when she progressed because her tolerance of bortezomib had diminished somewhat, therefore going to monotherapy, recognizing her deletion 17p. In second line, she got daratumumab pomalidomide index for about a year. Again, a partial response. The third line, we chose to bring back a proteasome inhibitor, and actually she did very well with this and benefited also from bringing the alkylator as an older patient into the mix and tolerated treatment really quite well. But then unfortunately, after about 17 months, developed progressive disease. Now, an important point in her is not only did she have hypertension, but she also had significant cardiac disease, making carfilzomib challenging. So in this context, the patient is now progressing again, has doubled her M spike, free kappa light chains are rising. She moreover clearly has end organ injury reflected by symptoms of bone pain, hypercalcemia, albeit modest, and creatinine impairment, as well as some suppression of her counts. So your current clinical practice, what treatment would you recommend next for this patient? Would you consider an antibody drug conjugate such as belantamab? Would you refer the patient, recognizing she is 78 years old and has significant cardiac disease, for CAR T-cell? Would you revisit an anti-CD38 regimen, recognizing that she's already had this? And at the same time, of course, would you think about carfilzomib even though she has clear cardiac problems? Then, excitingly, would you consider a bispecific antibody? Or in fact, would you consider, particularly given her 17p disease, and the fact I will share with you that she was relatively robust from a GI standpoint, what about selinexor-based therapy? And then finally, would there be any role for a combination which would be novel like venetoclax? And then I guess 7 would be uncertain. What would you do? So if you can kindly poll on that, that would be great. Oh, sure. So I think folks are polling now. Lovely. So antibody drug conjugate like belantamab seems to be popular, and then a bispecific such as teclistamab, and selinexor coming in third, which I think is very reasonable. And I think folks being cautious appropriately about CAR T, carfilzomib-based therapy. And obviously she doesn't have 1114, so venetoclax not being attractive. So excellent answers. So just moving on, we'll go to the, I'm sorry, I apologize, just to give you my choice in this patient, I would definitively think of belantamab mafodotin with the appropriate caveats of molecular management. So moving on, what about a fit patient with heavily pretreated disease? This is a 74-year-old gentleman. He basically has IgA disease, IgA kappa, and has basically ISS stage 3 disease, but standard risk otherwise, relatively fit and with normal cytogenetics. So his initial treatment had consisted of RVD, and in this context, he did get transplantation some years before with lenalidomide maintenance for 6 months. He unfortunately did have an early relapse despite this, and received DCEP chemotherapy to receive then in that context debulking of disease, followed then by carfilzomib, pomalidomide, and dexamethasone. And despite his sort of more favorable features at presentation, what you can see here is he has worsening disease. In fact, he only benefits for KPD for approximately 4 cycles. He's converted to Dara-KD, and he's on daratumumab, carfilzomib, and dexamethasone in line with the Callander trial. But unfortunately, literally within the cycle, is showing evidence of progressive disease. And that context, bone marrow has confirmed progression, as well as problems with his white count. And so in that context, what would you do in your current practice? He's 74 and relatively fit. Would you consider an antibody drug conjugate such as belantamab? Conversely, would this be a gentleman who would be very appropriate for CAR T? Obviously, a re-challenge with a different anti-CD38 regimen, bispecific like teclistamab, again, selinexor, venetoclax plus dexamethasone, or what would you be uncertain about what to do? So please, if you'd be kind enough to vote on this, that would be great. Yes, and I think that's a very excellent choice from the audience. Moving this gentleman to a CAR T program and for referral makes absolutely good sense in my view, and is an excellent choice and fairly unanimous in that regard. So we'll just now move on to the pre-survey for the context of our conversation today. When we consider selinexor-based therapy, which of the following would you discuss? And we recognize the challenge with selinexor is weekly dosing, go low and go slow is always my approach. But antiemetic prophylaxis and considering IV hydration for patients at risk of dehydration, dose reductions for concomitant CYP3A4 inhibitors. Would these other considerations be a concern? Increased potential for second malignancies, initial hospitalization for administration, a need to follow a risk evaluation and mitigation strategy. This is for selinexor. So which of these would you consider you are addressing selinexor with a patient? Yes, and the audience is spot on. Thank you, everyone. Really, the antiemetic prophylaxis is key. Getting ahead of these symptoms is key. The use of Zyprexa at night, Virubi, if insurance will allow, and basically there are no increased risks for secondary malignancies. There's no hospitalization required, and there's no REMS associated with selinexor. It's just proactive management. And certainly in my own practice, starting at lower dose weekly in combination classically with a proteasome inhibitor, we've had actually excellent results in that context. So thank you, everyone. So with this, I will move quickly into my talk, and recognizing we don't have a ton of time, so I'll move through my slides relatively quickly because I really do want to get to Noopur's presentation. I think what's so important, just as a conceptual point, is to understand that myeloma is an incredibly complex disease, and truly one size does not fit all. And so we're blessed in the current therapeutic landscape to have choices that we can tailor for our patients. And to meet that challenge, we have obviously an array of exciting new drugs. And we're blessed really with now at least 14, possibly 15 or 16 shortly. And the critical question is, how do we sequence these therapies in terms of our strategy? And a critical point to share is that I'd love you to think of myeloma strategically. This is a long haul. It's a marathon, not a sprint. And in that context, I think it's very important to consider what you do early in the patient's management, and therefore what you do later, especially in the relapsed refractory space. Now, with that in mind, there are sort of key targets in myeloma to think of scientifically. Obviously, genomic abnormalities. This is a highly unstable disease, where the mutational burden is incredibly high at diagnosis and can be magnified potentially by therapy. Having said that, combination treatments are absolutely key. And in terms of the targets that we use, excess protein production, of course, overcoming immune suppression are sort of fundamental constructs. Now, what I'm going to focus on in this part of the conversation is selected novel targeted agents, but I really want to reiterate that our treatment landscape is truly changing, and you heard so nicely from Natalie about this, so I'm not going to dwell on it, but suffice to say, combination strategies rule, but then as you move beyond into 4 prior lines, we have obviously the CAR T platforms, which you'll hear about in a moment from Noopur. I will touch on belantamab. We'll also hear from Noopur about the bispecifics. But a critical challenge is, what do we do in this sort of space between 3 and 4? Now, I want to reemphasize a point that was very nicely made by Natalie, that you have general principles to bear in mind, and they're summarized here. In the interest of time, I won't dwell on them other than to suggest that you think about the patient, think about the disease, think about prior therapy, and above all, patient goals. And I think Natalie touched on that very well. And then conclude, do you think triplet, quadruplet, and where to go? And what I would say there is just aware of kind of one size fits all. Natalie already showed you this, but I just want to emphasize that whilst we're certainly clear that doublets don't make sense, perhaps, and moving to triplets makes sense, this study took us somewhat by surprise in a very pleasant way. Not only did we see the magnitude of adding the proteasome inhibitor to the immunomodulatory platform, but above all, this is an important point, that we saw 0 COVID mortality in this study. And our enrollment was peaked during the pandemic. And above all, we also had an outpatient and oral therapy approach that was particularly appealing to our patients. And then as we go from the other side of things, when you go to multiple combinations, let's think about that for a moment. And there were two very nice combination studies presented at ASCO, and I just select them by way of choice because Andy Yee is Noopur and my colleague who led this trial, and it was a privilege to be part of this. This was essentially combining daratumumab with carfilzomib, pomalidomide, and dex, and in a heavily pretreated population who'd been previously exposed to pomalidomide and carfilzomib, so other drugs had been seen before, we got an overall response rate of 95%. So please don't forget that you can recombine drugs that have been seen before and bring that platform together. And not to be outdone, there was a very nice patient abstract from Dr. Kumar showing that when you put ixazomib pomdex and adding dara, you can see remarkable response rates in the order of 84%. So these exciting combinations are key to bear in mind. So with that in mind, what next about new drugs and new agents? Well, obviously selinexor has been approved now for a number of years, but I did want to spend just a few moments on this. XPO1 inhibition is an entirely new target, and it's very important in myeloma pathobiology. And suffice to say, please think about it in the context particularly of 17p deletion, and above all, think about its synergy, which we've demonstrated with proteasome inhibition, such as bortezomib and carfilzomib, and also with lenalidomide, both lenalidomide and pomalidomide, both in vitro and in vivo. Now, its approval was driven by a single-arm study looking at selinexor plus dexamethasone, recognizing steroids synergize with selinexor. And in that context, in a very difficult-to-treat population, progression-free survival around 4 months was achieved, but above all, there was a very reasonable DOR generated. The response rates were around 30%, with a minimal response rate or better of around 40%. But this was further validated by the success of the Boston trial, which clearly showed in combination with a proteasome inhibitor substantial clinical benefit. And this was seen across specific patient subgroups, very interestingly in older patients in particular, and especially in those patients with deletion 17, so 17p. So an important construct and an important option to have, particularly when we combine them with other drugs, such as, for example, I already touched on the carfilzomib platform, but also bortezomib, pomalidomide, and indeed daratumumab. So selinexor constituting an important part of the therapeutic armamentarium. Now, a couple of things to emphasize about toxicities, though. Thrombocytopenia and neutropenia are real, so consider growth factor support. The emetogenesis of this regimen is important. So the use of olanzapine or I can always struggle to pronounce this. I'm just going to stick with olanzapine and roller for short, together with, of course, ondansetron makes a lot of sense. Recommended monitoring, of course, is critical, and appropriate hydration is right. Now, I think it's very important to recognize this construct of starting low and going slow, and these are some of the guidelines that are available to you when you're considering it. So in this next question, I have a quick question for you. In your consultation with a patient with a relapsed refractory disease, which of the following would you discuss when considering selinexor-based therapy? Obviously, antiemetic prophylaxis is what we touched on and covered already. So I'm going to move now very quickly to venetoclax. I think this is an incredibly important drug. Obviously oral, it inhibits BCL2, and in particular, when deployed against T1114 disease, is remarkably active. I think what's important to share with you, though, is that the non-1114 population, whilst they do see responses and PFS gain, see an inversion of survival, which points to some of the challenges as we think about tailored therapies. And indeed, truly venetoclax is targeted, but above all, I think very effective in 1114 translocated patients and all patients with BCL2 overexpression. It needs to be used only in that setting, in my view. The Bellini trial really crystallized this, as illustrated in this slide, and above all, showing the value of following studies for overall survival. You can see here that the survival signal clearly shows the benefit of the use of venetoclax in 1114 disease, but outside of that, obviously these hazard ratios flip, which generated real regulatory problems. What's good news here, though, is that we do have the Canova trial coming, which I think will firmly establish, hopefully, the benefit of venetoclax in 1114 disease, and as a phase 3 study will allow us to have approval, hopefully, for venetoclax, and thereafter much better access for patients to venetoclax accordingly. I do want to close on the venetoclax story with one other comment. This is a super paper from Dr. Costa and colleagues published last year, looking at venetoclax combined with carfilzomib and dexamethasone. And above all, as you can see here, with the combination of venetoclax and carfilzomib, a really nice response rate seen. Overall, 80% PR or better, with a nice proportion of complete responses seen. And these were truly durable. If you look at the median PFS, it was 23 months. So a very exciting signal. And when you look at the 11-14 patients, obviously the greatest benefit seen there as well. Now, into other new novel targeted drugs. Very important one to share with you is the peptide drug conjugate melflufen, an entirely novel mechanism. This is what I borrow a term from Pete Voorhees. He describes this as a Trojan horse, and I think it's a very good metaphor. You deliver literally the alkylator warhead into the snout of the disease, and importantly, it's only or highly selective to plasma cells due to a number of features, diffusion characteristics, and the fact that this is a highly lipophilic drug, whereas of course traditional melphalan and other alkylators are actually lipophobic. Once inside the tumor cell, aminopeptidases, which are very heavily overexpressed in myeloma, cleave the compound and release the warhead, resulting in maximal DNA damage. So this drug, when you give it to patients, is not associated with alopecia or mucositis. It's a once-a-month infusion combined with dexamethasone. We originally had accelerated FDA approval, but this ran into regulatory storms last year. But fortunately, I think we're now finally back on track, especially after the European approval that was given earlier this year, full approval, in fact, from the regulatory agencies. And you may say, well, how did this all come to pass? Very quickly, to share with you the Horizon data that was the platform for the accelerated approval. This study demonstrated an overall response rate of 30% with a clinical benefit rate of 45% in a heavily pretreated triple-class refractory population. And above all, was very active in the context of extramedullary disease, which I think is a critical thing to share. And in that same context, when we looked at duration of response for patients with PR or better, we saw these responses to be durable. And when we looked at primary subgroups, you can see here in the extramedullary group, obviously work to do, but this for patients in whom they were all CD38 refractory, I think was an encouraging signal. So an important single agent signal from that regard. The confirmatory trial which followed, which as having just showed you some Bellini data, I think is kind of interesting because it points to this issue of subgroups in myeloma and specific target populations. In this study led by my colleague, Dr. Frederick Schesvold and Pieter Sonnefeld, the teams there randomized patients to melflufen and dexamethasone versus pomalidomide and dexamethasone after lenalidomide failure. This was designed a few years ago, but what was clearly shown was a PFS benefit to the melflufen dex versus the pom dex, recognizing that this is a head-on-head comparison between two MOAs. But what was clearly apparent as well, the clinical benefit was very clearly in those patients who had not had prior autologous stem cell transplant. And given the European enrollment to this trial being dominant, in that context, those patients who had prior transplant were within typically 1 to 2 years of their transplant when they were assigned to treatment arms in the study. So perhaps not surprisingly, melflufen dex struggled in that context, and pom dex itself performed very well. The challenge for the study design, of course, was that it meant that there was a confounded signal in the overall survival trend. And what was particularly interesting was the survival benefit seen for those patients with no prior transplant in favor of melflufen, whereas conversely, of patients that had prior transplant, this was not the case. So fortunately, this has been figured out and some interactions have been better understood. And in that regard, with the focus being on the non-previously transplanted population, certainly the European Medicines Approval Agency went forward with the full approval on that basis. So changing gears somewhat, I want to touch now on immune therapy and talk to you very specifically about the antibody drug conjugates, because you're going to hear very nicely in just a moment from Noopur on CAR-T and bispecifics. I'm also going to talk to you about a very exciting area, which is, of course, cell mods. Very quickly, I think everyone's very familiar, the mechanism of action of belantamab mafodotin, and really this in the same way as you saw the peptide drug conjugate delivering the warhead to the snout of the disease, and the antibody drug conjugate by targeting BCMA delivers the auristatin warhead as an immunotoxin, which has profound effects to the tumor cell. And of course, the pivotal work from DREAM-1, led by Suzanne Trudell, established the overall response rate that was very promising, and at the same time provided the platform for DREAM-2 by our colleague Saga Lonial. With Saga's leadership, this led to accelerated approval on the basis of the results of DREAM-2, where a very solid response rate of around 30% that appeared to be durable was established. When you combine belantamab mafodotin with other drugs, the response rates nicely improved. This is a representative example from Dr. Rakesh Popat and his team, where you see a response rate of 80% when combined with bortezomib in a relapsed refractory population. And we're looking forward to the DREAM-3 study, which is coming soon, which hopefully will provide the basis for full approval for belantamab. Now, a very important point is the keratopathy. And I think what's incredibly important to share here is that this requires the expert involvement of an ophthalmologist, but above all, it's a manageable toxicity. What we've really learned is that this is a reversible process, and whilst it's challenging from a logistic point of view, with the appropriate integration of an ophthalmology consulting service as well as clinical assessment, this has proven manageable, particularly if you reduce dose and space out infusions of belantamab, so a critical new platform. Now, in terms of other cellular therapy approaches, I just want to touch, if you will, on immune therapy approaches. I'm going to next move to CELMoDs. But before that, very quickly on one thing, the immunoconjugate, immunocytokine TAC573, and I beg your pardon, I should have mentioned this earlier. This basically is an exciting new compound coming, TAC573, and just in the interest of time, just want to emphasize that this is showing encouraging preliminary data with an overall response rate of around 40%. This was very nice data presented at EHA this year and previously at ASH by Dr. Vogel at the end of last year. So please watch this space. So back to where I was about CELMoDs. Well, very quickly, just to share with you that these are really very exciting compounds. They target the degradation of Ikaros and Aiolos and drive this much more profound in the inhibition of these key transcription factors, and by so doing engage profoundly in the cereblon E3 ligase complex. Now, with that in mind, iberdomide has moved forward rapidly and has been shown in combination to be very active, especially with dexamethasone, response rates around 30% and an excellent tolerability profile. And in that context, we've seen some really interesting clinical benefit as reflected by these survival curves, showing obviously some promising data in the context of single-arm trials. Now, a more powerful CELMoD is mezigdomide, which has been recently christened as such, originally known as 92480. This is even more powerful than iberdomide, and in preclinical studies is probably the most potent in this category, and really I think can be thought of as a degrader. Now, in that context, our first in human experience with mezigdomide has been really quite promising. I think the takeaway from mezigdomide is we're seeing a response rate of around 50% in a population where with iberdomide the response rate was around 30%, pointing to it. What was particularly interesting too is activity in extramedullary disease, which I just touched on as an important challenge. And as you can see here, we see responses in that setting, which is remarkable. And then finally, when we combine it with other drugs, the usual synergies are particularly encouraging. And we presented this at IMS, showing that when you combine it with bortezomib, response rates are dramatic at around 70%. They're durable. And then when you combine again mezigdomide and the lower dose setting, or rather the maximum tolerated dose setting, we were very impressed in our dose expansion cohort. This response rate actually improved to around 80%. And then not to be outdone, when we combine mezigdomide with carfilzomib, at present at least, we're seeing a response rate around 60%, recognizing that it's early days. Now, I'm going to wrap up here with a couple of conclusions and future directions, but certainly for mezigdomide, this is an obvious new direction that we're going in, which is combining it with multiple agents for the relapsed refractory setting. One point I want to make is that with mezigdomide, we have not seen COVID-related mortality, and the overall rate of COVID-19 infection was actually 15%, but with no associated mortality to date, which I think is an important positive. Now, I want to finally conclude with these conclusions that I think the next wave of immune therapies are crucially important in the relapsed refractory setting. baseline immune function is clearly a barrier to success. And what I've shared with you are obviously antibody drug conjugates, immunotoxins, and then other small molecule approaches. But what's very, very important is to recognize the real value of immune strategies, which then leads us to obviously Noopur's presentation in a moment. Just before we go there, let's touch very quickly back on our cases. I won't dwell on the actual details because we've already covered them. So just because this is a required part of our program today, we'd love to have your thoughts on what you would do next for this patient, recognizing that this was the frailer older lady. What would your choices be? Excellent. And this is very much confirming the educational value of what we've just talked about. Thank you, everyone. And then finally, on to the next part. It's my pleasure to hand over to Noopur to talk to us about CAR T cells and bispecifics. Thank you very much.
Great. Thank you so much, Paul and Natalie, who went before me. You've covered most of the data on relapsed refractory myeloma. And what I will do in the last 15 minutes or so is talk to you about CAR T cells as well as bispecifics, which as of right now remain investigational. I just want to remind all the listeners to punch in their questions because we are going to try and leave some time for questions towards the end of this session. So I'm going to start out with antibody-based treatments. And by way of introduction, I just want to give you all a sense of what these antibodies are all about. Natalie very nicely talked to us about the naked antibodies, which you all know of as daratumumab, directed against CD38. You also heard very nicely from Paul about antibody drug conjugates. Belantamab mafodotin is an example of this, and this remains an antibody with a warhead, as in the case of belantamab mafodotin. And for the purposes of this discussion, I'm going to focus on these bispecific T-cell engagers. Now, bispecific T-cell engagers have the potential to overcome the limitations of the immunosuppressive microenvironment. They have the ability to redirect your T cells to try and kill the tumor cells. Now, most of the bispecifics we have currently in clinical trials are being directed against BCMA. So it's the same antigen which Paul mentioned to you about belantamab mafodotin, which targets BCMA as well. We have several different BCMA-directed bispecific T-cell engagers, and these usually have an IgG like an antibody structure, which retains its Fc function. It has two arms to it, one arm targeting the BCMA, the other arm targeting the T cells, and these T cells are then directed towards the tumor cell to cause tumor cell killing. We did have BITE technology, which advocates for better tissue penetration. As of right now, the Amgen BITE is not being further developed currently. We're going to talk about the one which is furthermost in its development, and this is teclistamab. Teclistamab is a bispecific T-cell engager directed against BCMA, as I've already mentioned. There's a phase 1/2 trial, which has now been published in First Lancet Oncology and the New England Journal of Medicine, with Philippe Moreau leading the effort there. Close to 165 patients have been treated, and these are extremely refractory patients. So nearly 80% of them are triple-class refractory. Very high proportion of these patients have high-risk cytogenetics. If you look at the overall response rates of these patients, the overall response rates is about 63%. And if you look at patients who achieve a stringent CR, close to 35% of these actually achieve a stringent CR. And we're seeing MRD negative disease with a bispecific T-cell approach as well. This data has translated into very nice progression-free survival with a median progression-free survival of 11.3 months in patients who were treated with teclistamab. If you look at the overall survival of this patient population, it was 18.3 months. Now, there's another bispecific T-cell engager. This is elranatamab, which is again furthermost in its development. This is data from their phase 1 trial. Again, about 55 patients, overall response rates very similar to what you've seen with teclistamab, about 64% and close to 26% of these patients achieving an MR complete response. A significant proportion of these patients also achieving MRD negative disease. And what was really critical in this study was a lot of these patients had had prior exposure to BCMA and yet BCMA-directed agents, and yet you were seeing responses after using a bispecific T-cell engager. This is just a list of all the different bispecific T-cell engagers which are in clinical trials. As of right now, we are hopeful that teclistamab will be the first in class to get approved soon. It's already got EMEA approval, and we're waiting to hear from the FDA. And following that, Elran is the next in line, and then I've listed several of these. The bottom line with all of these, they've been tested in the very relapsed refractory space, and you're seeing high response rates with the majority of these bispecific T-cell engagers. A thing to note about this is the fact that these bispecific T-cell engagers do cause the same kinds of toxicities that you see with the CAR T-cells, including CRS and neurotoxicity, but the grades of CRS and neurotoxicity are very low with all of these bispecific T-cell engagers. What about combining bispecific T-cell engagers? Well, you have data now with TRIM2. This is a phase 1b study combining now teclistamab with daratumumab. And again, this was done in about 65 patients or so. Again, really heavily pretreated patients. Very important to see that a lot of these patients had had prior exposure already to a CD38 monoclonal antibody. The bottom line with this phase 1b study was you didn't see any added toxicity. So we already know what the toxicities with teclistamab was, some hematologic, some infection-related toxicities, but there was no compounding of toxicity when you start combining these bispecific T-cell engagers. The response rates were really very high when you start combining. Overall response rate in the entire cohort of patients was about 74%. And when you get to the recommended phase 2 dose, it was even higher. And as you can see from this plot out here, some of these responses were very durable. Obviously, early data right now, but important to recognize that these off-the-shelf strategies are easy to combine with what we already have as backbone drugs in the context of multiple myeloma. There's several novel bispecific antibodies as well, and these are bispecifics targeting different antigens. And I think this is going to be incredibly important, specifically in the post-BCMA space. So we have talquetamab, as well as cevostamab. Talquetamab targets G protein coupled receptor 5B. Cevostamab targets another protein which is present on multiple myeloma cells. This is the FcRH5. So having other novel targets is good. Again, data with this is still early, but we are seeing very high response rates and acceptable toxicities with these T-cell engagers as well. Moving on now in the last few minutes to CAR T-cell therapy. Obviously, CAR T-cell therapy is not off the shelf. It is something which requires a little bit of logistics in terms of trying to get a patient to CAR T-cells. A patient has to go through the leukapheresis. We then have to collect these lymphocytes and send them off so that you can transduce them with the CAR T-cells, and then finally get the patients back in. We generally give them a little bit of lymphodepleting chemotherapy with Cytoxan and fludarabine over 3 days, followed by reinfusion of the CAR T cells. So the process from actual collection to the infusion can be anywhere between 4 to 6 weeks. So it does require a certain level of planning. It does require trying to refer early so that you can get everything in order for your patient who has progressive multiple myeloma. I'm going to talk about 2 of the drug products which are approved. I'll start off with ide-cel or idacaptogene becleucel. You can see out here that this was approved based on a phase 2 data set, the KARMA trial, which was led by Dr. Nikhil Munshi at Dana-Farber, and 128 patients were treated. The overall response rate of this patient population was 73%, with about 39% of these patients achieving a stringent CR or a CR. What about the other CAR drug product? And this is cilta-cel or ciltacaptogene autoleucel. And this was again approved based on a phase 2 trial, CARTITUDE-1, which included 97 patients, again, all very refractory to their prior lines of treatment. The difference between ide-cel and cilta-cel is cilta-cel seems to have a biepitopic binding of BCMA. You're seeing extremely high response rates here. And in fact, more than 95 or close to 95% of these patients achieving a very good partial response or better, with a stringent CR seen in about 55% of these patients. Obviously, with all CAR products, we do see cytokine release syndrome and see neurotoxicity. I don't like comparing the two because it's not a head-to-head comparison. This is 2 different patient populations, but nonetheless, with cilta-cel and ide-cel, you do see CRS. The timing of CRS is a little bit different. Early with ide-cel, a little bit later with cilta-cel, and these could have implications as to how you can consider using outpatient versus inpatient CAR T cells, because that's something we are all thinking about and talking about. In terms of neurotoxicity, in general, the neurotoxicity signal, at least in myeloma, is extremely low. We do see a little bit of neurotoxicity in less than 10% of patients. There's some delayed neurotoxicity, which has been seen with cilta-cel. It has also been seen with ide-cel in a subset of patients where they see a Parkinsonian-like syndrome, which can be progressive, and that is seen in a small minority of patients. What about the progression-free survival with CAR T cells in multiple myeloma? With ide-cel, if they've achieved a stringent CR, their PFS is about 22 months. With cilta-cel, more than 60% of patients are remaining progression-free at about 2 years. We're still, unfortunately, not seeing a plateauing of these survival curves in the context of myeloma, the way you see them with the lymphomas, and I've just put the comparison for lymphoma out there. Nonetheless, I think we are doing better now, specifically with the cilta-cel drug product, but clearly we have ways to go and we have the potential of doing a whole lot better. So in terms of what do we do next, there's a lot of things which are ongoing already, and we are beginning to try and understand the mechanisms of resistance to anti-BCMA CAR T cell therapies, which could be tumor cell intrinsic, it could be CAR T cell intrinsic, or it could be microenvironment dependent. And to address some of these, we are using different strategies. For example, if you have T cell intrinsic problems, one can think about using an off-the-shelf CAR T cell approach. In this case, an allogeneic CAR T cell has been used. The benefits of this clearly are no waiting time, it's off the shelf, and it can be given to patients. So there's an ongoing phase 1 trial, and the key findings here is about 40 patients have been treated, and you're seeing an overall response rate of 70% plus. So really there are strategies wherein if you're unable to give a patient an autologous CAR, one should be thinking of allogeneic CARs. What about other strategies? If you have BCMA downregulation or BCMA loss, we are using a gamma secretase inhibitor. The way the gamma secretase inhibitor works is it increases the expression of BCMA. An ongoing trial has been done, and I think a word of caution here, and we have to wait on the data. We do see a slightly increased signal of neurotoxicity when you start using a gamma secretase inhibitor. We'll have to follow these patients a little bit longer, but this is one potential strategy to try and increase expression of BCMA. We have seen biallelic loss of BCMA in a small minority of patients. It's in less than 3% of patients. Once you look at the whole data set, what does one do in those patients when you use a different target? I mentioned a bispecific T-cell engager against GPRC5D. Well, there is a CAR T-cell product against this as well, and we're seeing quite high response rates with this MCAR H109 in the relapse refractory space. A lot of these patients have already received a BCMA-directed target, and still about 75% of these patients are responding to this new CAR, which is being developed by Eric Smith at Dana-Farber. What about the future of CAR T cells and or bispecifics? Well, I think looking at different targets, armoring our CARs even more, and using sort of combinatorial approaches where we may consider, at least in a subset of patients, thinking about using a maintenance strategy. The future of T-cell engagers, this is already in the works. In fact, we are thinking of using tri-specific antibodies. So it's not just engaging the T cells, but also engaging some of the cytokines so that some of those resistance mechanisms that I talked about could be overcome by using some of these future strategies in the context of myeloma. So I think targeting BCMA, certainly based on the data which Paul has shown you, which I've shown you, is certainly a new standard. We have several different drug products. You have the antibody drug conjugate, you have the bispecific antibodies, and you have the CAR T cells as well. And the challenge right now is how do we pick one versus the other for our patients? So currently, I think our understanding for sure is that the immune system is really quite important across the spectrum of multiple myeloma. We've demonstrated over and over again that BCMA is a validated target. We have all of these drug products. And in the future, we're really going to begin to dissect out as to how does one combine or how does one sequence some of these approaches. And the next generation approaches, which I've just very briefly touched on, is going to be a really exciting avenue of research in the next several years. So we're going to go back to some of the cases that Paul has mentioned. And again, I'm not going to revisit this, but remember, this was the heavily pre-treated patient who Paul had mentioned, who had lots of prior lines of treatment. And this patient, after we've gone through all of the previous discussions, I'd like you all to just think this through and pick one of the options. Would you consider belantamab mafodotin? Remember, he's the fitter patient. Would you consider CAR T cells? Would you consider a combination of DARA or ESA with some of the approaches that Natalie has mentioned, or some of these other things mentioned on this slide? I'm going to wait for you all to respond, and we'll see. Yeah, no, that's great. Thinking about CAR T cells specifically in a patient who is fit is something we should all be thinking of. And while waiting, since we have these drug products approved, we can always try and bridge with some of these other approaches as well. So with that, I want to thank you all for listening. I'm going to turn it over to Paul because we do have a few questions, Paul, in the chat box, and happy to participate in the panel discussion.
Thank you, Noopur. That was absolutely fabulous. A tremendous amount of outstanding information shared with everyone within literally an hour of time. So tour de force. We do have some great questions. I think we'll start with the first one, and I'm going to bounce this to Natalie. One of our audience questioners asks about the rationale from going to IMiD to IMiD. So in the lenalidomide refractory patient,
Sure.
moving to an IMiD platform, what do you think?
Yeah, I think, it certainly as a single agent or a doublet, I think we've got a number of studies where that's been looked at, and I think you can count on a response rate about 40%. That's pretty consistent. I mean, it is an easy regimen, but I think, as you mentioned as well, I think for the fit patients, if you were considering going from IMiD to IMiD, you've got to probably bring along another partner here, either an antibody or carfilzomib. Now, just as you mentioned, I think the biggest lack with these newer drugs is just sequencing. We just really don't know that. It's a lot of this is empiric, as you know, but I think, just going from say len to pom, I think that the response rate you're going to tend to see is going to be in the 30 to 40% rate only, just by itself.
No, I agree. And I think the important point, you nailed it, Natalie, by saying it's the dance partner, right? So a proteasome inhibitor can be partnered. We showed that with optimism, obviously. Carfilzomib, if they're bortezomib exposed and or refractory. And to your point, an antibody is key. And I was particularly struck by the Alliance data, where a simple COVID-friendly platform with ixazomib, you got 20 months of PFS, whereas 7 in the control. So really an excellent point. Another thing to bear in mind is immune exhaustion. One thing we've learned, which has emerged from the OCEAN data set, is an age-based analysis that if you're older, immunomodulatory therapy can actually be less effective. In terms of PFS, you may see benefit, but OS may not be there, which is really interesting. And that's an area we're going to be exploring more. But I'd love to ask Noopur for her thoughts here as well, please.
No, I agree with both Natalie and yourself, Paul. As you know, most of the patients that we treat at first relapse are in fact lenalidomide refractory, because we maintain them on lenalidomide. And I think the choice is really, we do go to pomalidomide. And so IMiD after IMiD does work. The beauty of these IMiDs and some of the data that you pointed to with mezigdomide and iberdomide, most of those patients are refractory to lenalidomide and pomalidomide, and yet we are seeing amazing response rates. And I think the beauty of going from one IMiD to the next IMiD is the potency. We're seeing a lot more potent IMiDs, and they're able to overcome whatever resistance that was afforded by the previous IMiDs. The answer is yes, you can go from IMiD to IMiD. And I take your point, Natalie, about the slightly lower response rates there for sure.
Right, and the PFS is obviously the best example is again the Alliance, right? 7 months PFS for Pomdex versus 21 months when you bring in a proteasome inhibitor. My one caveat to this would be the age interaction, and I would just say watch this space, because as we think about the success of Maya, for example, Dara RD, and then Len refractoriness, and then what do you do at salvage in that point? Recognizing unique considerations in the elderly, because obviously, you don't have too many lines of therapy to play with in an older, frailer patient. And I'm just wondering if class switch will be more of an issue in an older population based upon some of the things we're learning about immune exhaustion and the impact of IMiDs in the elderly, where that benefit may not be as profound as we thought it might be, say, in the younger transplanted patient. And again, one of the clues might lie in some of the OCEAN data, but more to follow, hopefully, very soon. So on to the next question, which I think is incredibly important. And I'm going to ask Noopur if you'd mind tackling this one. When using these newer BCMA-targeted agents, what do you think is the biggest challenge in clinical practice?
Yeah, so I think one of the biggest challenges is what we all addressed. We have so many different approaches of targeting BCMA, and we really don't have a good idea of how to sequence some of these. Part of the reason for that is how these have been approved. So belantamab got approved first, then the CAR T cells, and hopefully the bispecifics after. We have no data on bispecific followed by any of these. And that, I think, needs to be studied. So that's going to be an ongoing challenge. I think when you start using either the T cell engagers or CAR T cells, most of that has been done at academic sites or centers, transplant centers right now. because of the early onset of CRS and neurotoxicity. And as at least the bispecifics get approved, the challenge is going to be how do we manage that acute toxicity with this? And finally, I think with all of the BCMA-targeted agents, because we're targeting BCMA, because we're getting rid of plasma cells, we're going to affect the immunoglobulins. We are seeing infections, which we've typically not seen otherwise. And that's something we all have to, as a community, think through as to what the right prophylactic strategy would be.
That's absolutely so. I completely agree, Noopur. Natalie, your perspectives on that?
Yeah, no, I would agree. I think we all expect that teclistamab will be approved pretty soon. I can't imagine that we're not going to have a REMS program, which stands for, risk evaluation and mitigation strategy. I would think there's going to be one. I don't know if you would disagree with that. I see that teclistamab will probably enter in the community, and I think we're just still going to have a little bit of caution. I think one of the interesting things, Paul, you were talking about belantamab. We really haven't seen a lot of issues with infection in belantamab. And I don't know if that's been your experience as well. Certainly with the bispecifics and perhaps CAR-T, I think we're a little bit worried about that B-cell aplasia that Noopur just mentioned. I don't know whether that's just a numbers game, but I think that's just been something that we've noted. We just haven't seen as you think you might, but we haven't.
Yeah, I completely agree. We have not seen an infection signal from belantamab mafodotin, and I think it's an excellent point. We also haven't seen any of the unusual CNS toxicity that's seen with the CAR-T platforms. I totally agree with you. I think that the practicalities of these approaches are going to be fundamental, and I'm very interested in what you say about the REMS idea, because I do think that COVID-19 mortality signal from the teclistamab study is important. Because we simply haven't seen the same COVID mortality signals in other trials in similar patient populations. So there's something, I suspect, very real there. I guess one question that I would love to close with for both of you, and perhaps I can take this back to Noopur and then to you, Natalie. Bispecifics, assuming they are approved, which I strongly believe they will be, we've got a host of them. Noopur, your thoughts? What do you think will happen? Do you think we'll just have one or two approved and the rest will have to duke it out in phase 3? Or do you think we're going to see a whole patch of approvals, perhaps across targets, and then have a true sort of kitchen sink of different choices?
That's a great question, Paul. I don't have a good answer for that. I think what's going to happen is having the first couple of them approved is going to happen. Elran and teclistamab is my sense. The others are what we've seen thus far, and it's hard to compare across trials. The response rates are similar, the toxicities are similar. So unless you have an advantage of one over the others, it becomes very difficult to have so many of them against the same target. That's just my thought. I don't know what you think, Natalie.
No, I think you're absolutely right. I assume what we're going to see is just the usual theme in myeloma, which is we're going to probably be combining bispecifics with other agents. And so, if one of the sort of bispecifics maybe in later line or later, more not closer to approval, ends up having some data with a combo that looks very, very important. They may use that route, I would assume, to get approval potentially.
Yeah, I would close by saying I so agree with both of you on both fronts. I think one of the critical things will be the different targets, right? That we'll have the BCMA platform, then we'll obviously have cevostamab as another example, and then of course the GPRC5D platform that Noopur touched on. So really exciting going forward. And the very good news is that I think our talks will have to be 2 or 3 hours.
I don't know that anybody wants that.
Well, I don't know anybody wants to be on those. You're right. Our next relapse refractory talk will have to be at least 2 hours. On that note, I think we'll wrap things up because I realize we're running over, and it's a busy midweek clinic day for most of us. So on that note, I just say an enormous thank you for your participation to everyone. I just want to especially acknowledge Natalie and Noopur. I just can't tell you how much I enjoy working with both of you and for doing such a wonderful job. And then obviously to Kristen and the whole team from CCO for providing such a fabulous platform for today. So thank you very much, everyone.
Thanks so much.
Wonderful. Thank you to all of our faculty for an excellent program and for answering some of our audience questions. And thank you to the audience for being here and participating in this program. Don't forget to click on the claim credit on the side of your screen to evaluate this program and receive credit. Downloadable slides will be available on our site soon, and we will use all of your excellent questions to help us develop additional programs on myeloma in the future. Thank you all for participating and enjoy the rest of your day.